Good morning, everyone. It's really a great pleasure for me to be here with you and to discuss the new data about the management of acné in adult women. Bonjour à tous, c'est un grand plaisir d'être avec vous et de discuter le management de l'acné chez la femme adulte avec les nouvelles approches thérapeutiques. Et donc, si l'on regarde aujourd'hui les liens d'intérêt, so the prevalence of acne in adult women has risen steadily, clearly over the past 15 years. Here you can see that you have significantly more adult acne in women. So the data which have been recently presented to the ERDV confirm the prevalence of acne in adult women with a peak around 20 years old and then in decrease after 50 years old, but remain around 50%. In 2024, this survey, which has been performed in Brazil, confirmed significant increase in subtype of acne in women over the age of 25, and the perception of acne as temporary condition that mainly affect teenagers had changed. That's important. For many experts today, we consider that we have a third form of adult acne, beginning in adolescence, followed by the disappearance of all lesions over several years, then relapse. And sometimes, so adult acne can start at 25 or even later. And finally, so we have a fourth adult acne starting in teenager and so always present even after 25. That means that you have three clinical aspects of adult acne. So the profile of adult acne is now well defined. Hereditary factors are very important. The second thing is that you can have high frequency of acne scar. Third, less severe than adolescent, very important, generally GEA1-2 rate. Severe hyperseborrhea are always present. Frequent retention lesion and mainly closed comedon. It's very rare to have open comedon. Frequent mandibular localization and premenstrual stress and care role of exposome factor, and we are going to discuss them. So, external factor, so which modulate adult acne that we have to take in account in our management, stress, diet, so medication, smoking, endocrine disease. So one thing which also is important is recent data using confocal microscopy confirm that the microcomedon have a greater number than in normal skin. In addition, they are more important in the mandibular region. But you have to think that you have this closed comedon in normal skin of adult woman acne. That means to treat, you don't have to treat the lesion, but to treat the surface. That's very important. Concerning the pathophysiology, we have three predominant factors in adult female acne: genetic, peripheral hyperandrogeny, and innate immunity. As you can see here, definitively, so the genetic factor is important. We have very, very often more than 50% family history of acne. Concerning hormonal factor, it is identified by premenstrual rash, frequent irregular, painful cycles, and often you have an increased hair growth in certain areas that are indicated here. At the biological level, it's not necessary So to make a biological exam for each patient, because it's a peripheral hyperandrogeny which is in the skin, not in the blood. If you use a blood sample, so you could have a very moderate increase of the HEA surface, and you will have a low level of sex hormone binding protein, but not necessary if you don't have other signs as hirsutism alopecia. And the hypothesis is that abnormal activation of androgen receptors, the sebaceous gland, associated with an abnormal activation of enzymes which are present in sebaceous, the of the different phenotype of QT bacteria 1A1. And so it's the same thing in adult women. It's phenotype 1A1, which is predominant. So, as I mentioned, acne in adult is often so mild acne. And to try to take in account in the management of our patient of the mandibular region, we decided to make a new grading named AFACE. In this grading, you have two scores. The first score, the score 1, is similar to the IGA or GEA grading. It takes in account all the adult phase from grade 0 to grade 5. But we add another score with the score 2, which is adapted to the mandibular region from grade 0 to grade 3, which is considered as severe. And then, after building this grading, we decided to propose an algorithm taking in account the specificity of adult women. So, for this algorithm, when you have only a mild acne, obviously, you are going to use topical treatment. You know very well benzoyl peroxide, topical retinoid. Avoid topical antibiotic because of bacterial resistance. And if you are relapse progression, then you are going to add oral cycling. What we have new as topical treatment, here you have the clascoterone, 1% cream. So clascoterone binds to the androgen receptor with a greater affinity than the DHT. Then the complex dimerizes and moves towards the nucleus, and then it reduces the transcription of gene, not only involved in sebum production, but inflammatory cytokine. And here you have the two randomized trials, which demonstrate that you have an efficacy of this hormonal treatment, mainly in mild to moderate acne. Here you have a very recent paper which has been published, which use a peel-off mask, and this peel-off mask is based on estrogen. 20 women, weekly application of this mask, which is placed by the investigator on a split face, that means on half face, and the other is the placebo. It's removed after 3 hours, and it's a weekly application, and the duration 8 weeks. As you can see, after 8 weeks, so in the estrogen treated side, you have a significant more effect on papule and pustule, but unfortunately, you have a relapse when you stop at week 16. What does it mean? It means that you need to have a maintenance treatment. So, obviously, the question now is discussed about the interest of probiotic in acne vulgaris. Clearly, we are always in the field of the research. However, which seems to be important is the use of oral probiotic in adult female acne. It's a randomized double-blind placebo-controlled 12 weeks. Here you can see the population. So you can see the probiotic which are used, and you can see the result compared to placebo with an improvement of at least one severity grade, which is confirmed in 50% of patients week 12 in the probiotic arm, so compared to only 30% in placebo arm. It's just preliminary results, so we need to confirm this result with oral probiotic. So now if we move to grade 2 to grade 5, that means more severe acne, here clearly, as we can see, it's the place of the anti-androgen, metformin and spironolactone. About metformin, just to remember, its main indication is polycystic ovarian syndrome, hyperpilosity, overweight, irregular period, and what is very important, increase of anti-Müllerian hormone. You know that it is important to treat this patient because they can have metabolic syndrome, diabetes, cardiovascular disease. And it has been shown in this systematic review and meta-analysis that metformin may be a useful and safe alternative to oral contraception, particularly in obese women. And here you can see the acne score, which is significantly reduced after metformin use in different studies which has been performed. So here it's a very interesting randomized trial. So comparing doxycycline 100 milligram daily to metformin 1 gram daily. And just at the topical level, the patient used benzoyl peroxide. And you can see that finally, so the results are very similar in the two arms. So similar result between doxycycline and spironolactone. But what is very important to take in count is that you have a significant quicker effect with doxycycline, with a plateau. So it's slower effect whereas metformin, but at the end you have a more significant decrease of lesion, both inflammatory and non-inflammatory lesion. It's why is it interesting to combine metformin and topical treatment, specifically fixed combination, to have a quicker effect. And the management, so you have to give 500 milligram once daily during the first week, then 1 gram one during the second weeks, and then it's followed by 500 milligrams 3 times a day, 1.5 gram for weeks 3. It means that you increase slowly metformin. If you have any adverse event, you stop to increase. The maximum daily dose have to be 2,500 milligrams. So the adverse events are mainly non